Bismillahirrahmanirrahim. Dear student, Assalamu alaikum. Today we are going to talk about the antiplatelets, anticoagulant, and thrombolytic agents. Before watching this video, I would like you to watch the animated video that I have uploaded on the Blackboard to know the normal process of blood clotting. Okay, so by the end of this lecture, you would be able to identify the different drugs used to prevent and treat thrombotic disorders, recognize the agent in the three classes, list the features and differences of drugs in each class. Along with that, you will have to recognize the mechanism of actions, the side effects, and the contraindication of these classes. So, starting from the significance of the blood coagulation. What is the significance of blood coagulation? If you can see, physiological hemostasis. Hemostasis is the clotting or the stopping of the blood after vascular injury, and it is a protective response to prevent the excessive bleeding, and this is followed by the vasoconstriction of the blood vessels, adhesion and activation of the platelets, and formation of fibrin mesh that you would have seen in the video that I have uploaded. So the first step in that clot formation is the activation of platelets. The second step was the activation of platelet coagulation factors. And the third step, that is basically the lysis of the already formed blood clot. So we will be discussing three classes of drugs in this chapter. Terminologies, you have to know these terminologies before moving further because these will be repeating in this lecture. So thrombus, if you see this picture, thrombus is a clot so formed often obstruct blood vessels leading to pathological complications. While embolus is a broken piece of this thrombus. So this broken piece can move around the blood vessels and can lead to blockade of the blood vessels in the peripheries or in the vital organs such as heart, lungs, or the brain. And that can lead to deep vein thrombosis in the peripheries, pulmonary embolism in the lungs, and myocardial infarction or stroke in the heart and in the brain. So that's why we need these anticoagulant drugs which can stop the formation of this abnormal blood clotting. Remember, normal hemostasis or clotting of the blood is important and is a very important physiological response to injury. However, this abnormal clot formation is not good. That can lead to blockade of the blood vessels and lead to severe complications. So that's why hemostasis. Hemostasis is the stoppage of blood flow through blood vessels or body parts. That's called hemostasis. However, thrombus is abnormal formation of blood clot. So thrombosis is abnormal phenomenon or pathological condition, while hemostasis is a normal response of the body towards vascular injury. Well, fibrin that you might have seen in the video, that fibrin is a fiber. It is a non-globular protein involved in clotting of the blood. So it holds these red blood cells, platelets to form a clot and lead to pathological complications. So three classes of drugs we will be discussing in this lecture. Number one is the antiplatelet drug. So antiplatelets are the drug which interfere with the platelet function. Anticoagulants are the drug which used to reduce the coagulability of the blood. So these drugs causing the inhibition of the clot formation. While thrombolytic, so these drugs affect the homeostasis and thrombosis in three different ways based on the three steps involved in the formation of blood clot. as you might have seen in the video, that the first step was the activation of platelets in the formation of blood clot. So we will be discussing here the antiplatelet drugs. Then the second step was the formation or the activation of coagulation factors. That is the factor 10, factor 2, which are playing an important role. Factor 2 is prothrombin. Inactive form of factor 2 is called prothrombin, and it is converted to thrombin, the activated form. So the second class of drugs are the anticoagulant, which inhibit the activation of coagulation factors. And the third class of drugs that are called thrombolytic drugs or fibrinolytic drugs. They basically break down the already formed clot by breaking down the fibrin threads which is holding the red blood cells, the platelets, to form a clot. Now this diagram shows the different steps involved in the formation of blood clot and also then the lysis of this blood clot. So it is important for you to know the mechanisms or the steps which are involved in the activation of platelets and then the formation of blood clot, because we will be discussing drugs which are inhibiting these different steps which are necessary for the activation of platelets and formation of blood clot. So just a brief discussion, or if you can see this diagram here, this is the platelets in the inactive form when the blood vessels are in normal shape and there is no injury. But whenever an injury happens, what happens, it causes the activation of the platelets that you might have seen in the video that is given very clearly there. So just look and go back and watch that again if you have not. Then what happens after activation of the platelets, it causes the release of thromboxane, A2, adenosine diphosphate, serotonin. All these are the mediator which further activate more platelets, and red blood cells causes the came here to form a clot. Okay, so what happens here when the injury is produced within the blood vessels? So the first step, that was the thromboxanes, ADP, all these are causing the release of this calcium from the calcium stores of the platelets, and calcium further increases the release of thromboxane A2 with the help of arachidonic acid and prostaglandins. So here the role of prostaglandin is very important in the activation of platelets. So we will be using drugs which inhibit the formation of this thromboxane. Okay, then the second class of the drug is to inhibit the release of calcium from the calcium store, because calcium also causes the further activation of these platelets. So if you can see here, this cyclic AMP is important for the release of calcium from the calcium stores. Normally, the higher the cyclic AMP, the lower will be the release of calcium. That you can see that it has a negative effect on the release of calcium. So we want to have more cyclic AMP here. And if you can see, we will discuss the drug adenosine diphosphate or phosphodiesterase inhibitors, PDE. So here, cyclic AMP is degraded by the phosphodiesterase enzyme. So if we want to have more cyclic AMP in the cells, we have to deactivate or inhibit the phosphodiesterase enzyme here in order to have more cyclic AMP. So the first class we will be discussing here in the antiplatelet drug is to inhibit the formation of prostaglandins, and that are the drugs that are inhibiting the cyclooxygenase enzyme, because cyclooxygenase enzyme is important for the formation of prostaglandins here. Okay, while phosphodiesterase enzyme are important for inhibiting the degradation of cyclic AMP here, and which will lead to the uh, inhibition of calcium release from the calcium stores. ADP inhibitors, we will discuss that is causing further activation of the platelets, and the four types we have here, these are the receptors. So these receptors, which are activated, it will further cause the binding of the these platelets with each other to form a clot. So these four types of drug we will be discussing is antiplatelet drugs. Then the second step is the formation or the activation of coagulation factors that you have seen. So there is a series of or chain of reactions. One is activating another. At the end, the fibrinogen is converted to fibrin, insoluble fibrin, which hold down this clot here to form, which hold down these platelets and red blood cells to form a clot. So in the second class, we will study or discuss the drugs which are inhibiting this coagulation cascade. Okay, so you might have seen that whenever clot is formed at the site of injury, after a few days it disappears by itself, and that is because of the plasmin that is produced in the blood from the plasminogen. So normally plasminogen is in the inactive form, and when it is converted to plasmin causes the degradation of this already formed clot. So we will have these. This is the third type. Thrombolytic drugs work here. This is the coagulation cascade that you might have, where you see that extrinsic pathway and intrinsic pathway. Both of them leads to the activation of factor 10A, while factor 10A leads to the activation of prothrombin into thrombin, activation of thrombin, and thrombin convert the fibrinogen, the soluble form, into insoluble fibrins, and that leads to the formation of clot here. So anticoagulant drugs work here. We will discuss it later. While thrombolytic drugs work here, that is causing the lysis of the already formed clot. So the first class we will discuss antiplatelet drugs, because platelet activation is the first step in the formation of a blood clot. And we will discuss the different drugs which are causing the inhibition of platelet activation. So antiplatelet agents play an important role in preventing atherosclerotic vascular diseases and thrombosis through inhibition of platelet aggregation. So this thrombosis is activated or inhibited by the aggregation or by inhibiting the platelet aggregation. And inhibiting the platelet aggregation, we have to inhibit the activation of platelets. So based on the mechanism of actions, these antiplatelet drugs are divided into four classes, and these mechanisms we have discussed briefly in that first picture. So we will be discussing here the thromboxane A2 synthesis inhibitor, the phosphodiesterase inhibitor, adenosine diphosphate antagonist, and glycoprotein receptor antagonist. These drugs, prostaglandin synthesis inhibitor, inhibit the platelet aggregation or activation by inhibiting the enzyme cyclooxygenase 1. Now, what is cyclooxygenase enzyme? Cyclooxygenase enzyme has play a very important role in the inflammation, fever, and also in the blood coagulations. Basically, we have to stop the production of thromboxane. Thromboxane causes the activation of platelets, and this thromboxane is produced from arachidonic acid with the help of cyclooxygenase enzyme. So if you have seen this, whenever an injury happens, these cell membrane causes the production of arachidonic acid with the help of phospholipase, and then arachidonic acid is converted to prostaglandins with the help of cyclooxygenase, and then prostaglandins is converted to thromboxane these thromboxane. So we have to stop the production of this thromboxane by inhibiting the cyclooxygenase enzyme. And aspirin is doing this job. Aspirin, you might know this. This is a very common drug belonging to the class of non-steroidal anti-inflammatory drugs. And it can also play a very important role in the inhibition of platelet aggregation. So now how it inhibits the platelet aggregation? For anti-inflammatory actions, the enzyme cyclooxygenase play an important role, while for the anti-platelet activation or anti-platelet effect, COX-1 is playing an important role. So the anti-inflammatory action of aspirin is because of the inhibition of COX-2 inhibitor, COX-2 enzyme, because COX-2 causes the production of prostaglandins and inflammatory mediators, while COX-1 is producing the thromboxane and other mediators which are responsible for the platelet aggregations, and also for it helps in the mucosal blood flow. Okay, so that we will discuss that. It could be the side effect. But you have to know here that COX-1 is playing a role in the platelet aggregation, while COX-2 is playing a role in the inflammatory mediators or inflammation. So in order to inhibit the platelet degradation, we have to stop this COX-1. For anti-inflammatory action, we have to stop the or inhibit the COX-2 enzyme. So now you might have seen that the aspirin can be used both for the anti-inflammatory action and also for the antiplatelet action. Now, if we have seen that aspirin can block the cyclooxygenase enzyme at lower doses, however, it can block COX-2 enzyme on higher doses. So for antiplatelet actions, we need a small doses of aspirin as low as 75 milligram per day. While for anti-inflammatory actions, we have to take large doses more than 375 milligrams up to 500 milligrams in order to inhibit the COX-2 enzyme. So that's why we can use this aspirin 75 milligram per day, and that is enough to produce this antiplatelet action by inhibiting only the COX-1 enzyme but not the COX-2 enzyme. So at this dose it will only have anti-inflammatory action, anti-platelet actions but not anti-inflammatory action. Inhibition of COX-1 is irreversible and the effect lasts for 7 to 10 days till new platelets are found. That's why this aspirin and related medicines reduces the incidence of stroke and myocardial infarction in susceptible individuals. Those individuals who are susceptible to form these abnormal clots or thrombosis in the blood vessels, this antiplatelet drug will help in the prevention of blood clot formation. So these can be used as a preventive measure for decreasing the chances of blood clot formation or thrombosis. This is the same diagram that we have discussed previously, that how this cyclooxygenase inhibit the platelet aggregation and the inflammation. Now the second class in this category are the phosphodiesterase inhibitors. Now what is the function of phosphodiesterase inhibitor? If you recall the first diagram where we have seen the activation of platelets, you might have seen that there we have discussed the role of cyclic AMP in the activation of platelets. So how cyclic AMP inhibit the activation of platelets? You might have seen here that more cyclic AMP is inhibiting the release of calcium from the calcium stores within the platelets. So we need more cyclic AMP here, because when this calcium is released, it will further activate the thromboxane, adenosine diphosphates. All these are further causing the activation of platelets. So we have to stop the release of calcium from the calcium stores. And this can be done by increasing the cyclic AMP. Now, phosphodiesterase enzyme play a very important role here because this cyclooxygenase phosphodiesterase inhibitor phosphodiesterase enzyme is responsible for the degradation of cyclic AMP within the platelets. So if we stop or inhibit this phosphodiesterase enzyme, this will inhibit the release of calcium from the calcium stores, and it will further inhibit the activation of platelets by inhibiting the thromboxane, adenosine diphosphate, and all these mediators. So here in this class we have the drug that is called dipyridamole that inhibit the enzyme phosphodiesterase. And when we inhibit this phosphodiesterase, it will lead to increased cellular level of cyclic AMP, which ultimately inhibit platelet aggregation and inhibit thromboxane A2. So it has been used in patients of transient ischemic attack or stroke with effects similar to aspirin, however does not increase the risk of bleeding. So it is not that much potent as compared to aspirins. That's why it has less risk of bleeding as compared to aspirin, and it can be used to inhibit the stroke formation, the stroke or a transient ischemic attack in susceptible individuals who can form abnormal clotting within the brain or the small arteries of the heart, etc. The third class in this category are the glycoprotein receptor antagonists. You know the function of these glycoprotein receptors. Basically, it is causing the aggregation of these platelets. If you can see, this is the abscesomab. It's a murine monoclonal antibody that binds irreversibly to this GP2B3 receptor and prevent binding of the fibrinogen. So if the fibrinogen is inhibited to be bound to these receptors, then what will happen? These platelets will not be able to bind to each other and will not be able to form an aggregate. So this is the action of these drugs. These are inhibiting the fibrin, which is fibrin is the connection between the different platelets to form an aggregate. It can reduce platelet aggregation by more than 90%. It is given intravenously mainly during and after coronary artery procedures such as angioplasty in order to inhibit the activation of platelets and the binding or the aggregation of platelets. This is the first one was a murine monoclonal antibody, while this is a synthetic inhibitor used for the GP2B and 3A receptor. So the main side effect for both of these drugs is the bleeding, because that can inhibit platelet aggregation by around 90%. So eptifibatide is a synthetic inhibitor of this GP glycoprotein receptor. The last class in this category are the adenosine diphosphate antagonists. So we have seen the role of ADP, that it leads to further aggregation of the activation and aggregation of platelets by indirectly causing the release of calcium from the calcium stores, which leads to further activation of these GP2B and 3A receptors, and that causes the aggregation of platelets. So they irreversibly inhibit platelet activation by blocking the adenosine diphosphate receptor on the platelets membrane, and which leads to the inhibition of GB2B and 3A receptor. So it is indirectly inhibiting the activation of these GB2, 3A receptors. Therapeutic use decrease the incidence of thrombotic stroke use for patients who cannot tolerate aspirin. So this can be used for those patients who cannot tolerate the aspirin because it has long duration of action and can irreversibly inhibit the cyclooxygenase. Most other side effects are the most serious side effects is of ticlopidine or the neutropenia, thrombocytopenia, aplastic anemia. Therefore, clopidogrel is the main agent currently used. So this clopidogrel is more safer as compared to ticlopidine, which have these side effects: neutropenia, thrombocytopenia, and aplastic anemia. So to summarize these antiplatelet drugs, we have discussed four classes of drugs within this category. The first one was the cyclooxygenase inhibitor, which was inhibiting the cyclooxygenase 1 enzyme, and the main drug in this class is aspirin. The second was the adenosine diphosphate inhibitors that inhibit the activation of ADP or block the ADP receptor on the platelets. And this is ticlopidine and clopidogrel. We have to mention here that food interfere with the absorption of ticlopidine, but not clopidogrel. So food is interfering with the ticlopidine, with the absorption of the ticlopidine, but not the clopidogrel. While we have discussed other class GP2, 3A, 2B and 3A receptor antagonist, and we have this antibody abscesomab, and the other is a synthetic drug, eptifibatide, that can inhibit the activation of or blocking of these GP2 and 3A receptor in order to inhibit the activation of the platelets. And the fourth class in this category was the phosphodiesterase inhibitor, which was inhibiting the enzyme phosphodiesterase. And phosphodiesterase increases the cyclic AMP, which further lead to the inhibition of calcium release within the platelet cells. So that's all about the antiplatelet drug within this class. Thank you. Okay, so students, in the next class of this chapter, we will be discussing anticoagulant and thrombolytic drugs. Anticoagulant drugs basically they inhibit the formation of clot by inhibiting the coagulation factor or inhibit the synthesis of these coagulation factors. So in this class we have two subcategories, that is heparin and warfarin, and the second class in vitamin K antagonist. So heparin and warfarin basically they inhibit the activation of coagulation factors, while vitamin K antagonist inhibit the synthesis of coagulation factors. So we will be discussing these two classes here. So heparins, these are the most commonly used antagonist, and they are the drug of choice because of their rapid action. So now coming to the mechanism of action of heparin. Heparin can be found as unfractionated heparins, that is a normal heparins, or it can be used as a low molecular weight heparin. So we have two types of heparins here. And what is their difference? We will discuss their advantages and disadvantages within the coming slide. But now I'll focus on the mechanism of action. So, but basically, what these unfractionated heparin do? They inhibit the activation of factor 10 and factor 2, because this activation is further causing the formation of fibrin or clot formation. So here they are inhibiting the activation. This A stands for the activated form. So this X factor is, this is the inactive form and this is the active form. So what it do, it in inhibiting the activation of factor 10A and factor 2A, while the low molecular weight heparins that only act here, that only inhibit the activation of factor 10. Now, how these heparins and low molecular weight heparin inhibit the activation of factor 10A and factor 2, and that is by the activation of antithrombin. Basically, antithrombin is also called factor 3A, and the function of this factor is to inhibit the activation of factor 10 and factor 2A, which is thrombin. So basically, what happens do, it is inhibiting this both factor 10A and factor 2A, while this low molecular weight heparins, it can only inhibit the activation of 10A. So they are a little bit more specific towards 10A, while unfractionated are non-specific. So what you will see here that heparins and most of the low molecular weight heparins, they are derived from biological source. While this fondaparinix, this is a synthetic analog of heparin. Normally, heparins have a high molecular weight, that is around 15,000 Dalton, while the molecular weight of low molecular weight heparins ranges from 1,000 to 10,000 Dalton. So that's why they are called low molecular weight heparins, and they have short fragments of heparin. The identification for this natural low molecular weight heparin is this parin. Whenever you see this parin, that means these are the natural low molecular weight heparins. Tensoparins, exoparins, deltaparins, all these are natural. While this fondaparinix, this is a synthetic low molecular weight heparin. Regarding the route of administrations, most heparins, they must be given parenterally, either through deep subcutaneous injection or intravenously. However, they should not be given intramuscularly, because that can lead to hematoma, is basically a clot formation within the vessels. So it's one of the most common side effects of these heparins. Normally it occurs with subcutaneous injection as well, but up to a lesser extent. So mechanism of heparins that we already have discussed, that heparins binds to antithrombin factor 3 and induces conformational change that accelerate the interaction of antithrombin with coagulation factors. And what are that coagulation factor? Factor 10 and factor 2. For the heparins inhibit both factor 10 and factor 2, the activation of factor 10 and 2, while low molecular weight heparins only inhibit the activation of factor 2, antithrombin. So heparin also catalyzes the inhibition of thrombin by heparin cofactor 2 and XA, which is our circulatory inhibitors. Pharmacokinetics. As we have already discussed, heparin is not absorbed from the GIT, therefore it must be given as intravenously or subcutaneously. It produces an immediate action on intravenous administration, but the onset is delayed up to 60 minutes when given through subcutaneous injection, and is contraindicated by giving through intravenous intramuscular injection. While warfarin, it can be absorbed rapidly and completely from the GIT, so it can be used as oral administration or for rectal administration. We will discuss the mechanism of action here for warfarin. These are the anticoagulant test and antidote for heparin and warfarin. So for heparins, the anticoagulant test that normally uses activated partial thromboplastin time. Because these heparines normally their effect is not predictable in different people. So they have to be, their blood coagulation ability has to be monitored through this test, and this is a kind of anticoagulation test to test the ability of the drug to coagulate. So they have some normal ranges. We don't have to go into that details. But what you have to know here is the test for the heparines and warfarin. So the blood anticoagulant test for heparines is normally done with APTT, or activated partial thromboplastin time, and the antidote for heparin is protamine sulfate. So it will reverse the action of heparins. While for a warfarin, the anticoagulant test normally used is INR, International Normalized Ratio, and the antidote for heparin is vitamin K. So the most main side effects associated with these heparins is the bleeding, thrombocytopenia, and osteoporosis. Thrombocytopenia is the abnormally small number of platelets and bleeding, because it's reducing the coagulation that leads to the bleeding. Most common side effects of these anticoagulant drugs. And osteoporosis can happen after long term of use. So this osteoporosis can lead to spontaneous fracture when used for more than 6 months. While other less common side effects are alopecia, which is very less common in around 5.5% of the patient, but it is reversible. Hypersensitivity reactions can occur to the heparins, which are derived from animal sources, and that can lead to bronchospasm, urticaria, and anaphylactic shock. And this is because of they are derived from these bovine lungs or porcine intestine. So they have not natural origin, but for synthetic heparins, this is less common. It can interact with the synthesis of aldosterone, and aldosterone, you know, that is an antidiuretic hormone. So you might have seen that aldosterone we can use for for diuretic effect. So it can lead to hypoaldosteronism, and that can lead to more urination. And since it decreases the, it inhibits the, and that and you might have noted that this aldosterone antagonist, that this is one of the class of potassium sparing diuretics, and their main side effect, one of the main side effects was hyperkalemia. So hyperkalemia is associated with this hypoaldosteronism, and spontaneous fracture that's associated with this osteoporosis. So in this slide, we are going to discuss the advantages or disadvantages of a low molecular weight heparin. So it has more advantages as compared to heparin, because it has a better bioavailability. It has a long duration of action, which reduces the repeated administration. It has predictable plasma time level as opposed to heparin. So that's why heparin has to be constantly monitored through APTT anticoagulant test. It has a lower risk of bleeding and osteoporosis, and also thrombocytopenia. However, one exception is that low molecular weight heparins should not be used in patients with renal failure whose creatinine clearance is less than 30. And that is because of the accumulation, because most low molecular weight heparins are excreted through the kidneys. So if the kidney is not properly functioning, it can bioaccumulate in the body. While the unfractionated heparin, its excretion is less or minimal through renal route. It has a very short duration of action, and in case of overdosing, it's because it has to be monitored through APTT. In case of overdosing, we can use that protamine sulfate, which will antagonize its effect. Therapeutic uses of heparins and low molecular weight heparins. Therapeutic uses, as we have discussed, it can be used for the venous thrombosis or pulmonary embolism associated with the clotting of the blood within the deep vein in the legs or in the lungs. And also it can be reused for the patient who have unstable angina or myocardial infarction, because that can be because of the blood clotting within the heart arteries. So wherever we have these abdominal thrombosis, it can be used for the prevention of this myocardial infarction due to thrombosis. A drug interaction. Heparins should be carefully used with drugs causing the changes in coagulation status or platelet function. So as you have know that aspirin can decreases the platelet activity. So it is also used as anticoagulant drug, and warfarin itself is anticoagulant. So these drugs has to be used with caution with aspirin. Along with that, it can antagonize the action of corticosteroid, insulin, and adrenocorticotropic hormone. In addition to that, heparin may increases the plasma level of diazepam. So basically, it is inhibitor for the diazepam, plasma inhibitor. So it decreases the metabolism of diazepam, which will increase the bioavailability of diazepam and can lead to increase plasma level of diazepam. The second class in this category is the warfarin, and how warfarin acts. Basically, it is a vitamin K antagonist, and vitamin K is necessary for the formation of gamma carboxyglutamyl reductase, which is the main component in the formation of factor 2, 7, 9, and 10. So what it do basically, it inhibit the formation of clotting factors 2, 7, 9, and 10, whose synthesis depends on the availability of vitamin K. So if we don't have vitamin K, we are inhibiting the formation of these coagulation factors and thus inhibiting the clot formation. Major adverse effects associated with this is hemorrhage, bleeding in the intestine, and brain can be troublesome. So these are the main disadvantage of these anticoagulant drugs, especially hemorrhage is the bleeding from the internal organs, and it's very difficult to be controlled. That's why these drug has to be constantly monitored through anticoagulant test. Other effects include allergic reactions, GIT disturbances, and teratogenicity. Since it crosses the placenta, therefore it is not given in the first month of pregnancy and also in the later stage of pregnancy. So that's why it should not be used during pregnancy. It can lead to teratogenicity in the fetus. Many drugs can interact with the warfarin. They can act as an enzyme inhibitors or enzyme inducer. So if any drug that is causing the inhibition of the enzyme responsible for the metabolism of warfarin, so it will lead to increased accumulation of warfarin. And if some drug is inhibiting the enzyme responsible for the metabolism of warfarin, so that will lead to increased level of warfarin within the blood. So these drugs, cimetidine, ciprofloxacin, increase plasma level of warfarin because they inhibit the enzyme responsible for the metabolism of warfarin, while this rifampicins and gracifulvine are enzyme inducer. They increases the metabolism of warfarin, so warfarin will have less bioavailability, while here the warfarin will have more bioavailability, so it will have more action here that will lead to increase anticoagulation effect, while here the anticoagulation effect will be decreased. So in both cases it can lead to complication. while aspirin and other NSAID can increase the risk of bleeding because they themselves are causing the inhibition of cyclooxygenase enzyme, and that would lead to inhibition of thromboxane synthesis. So they themselves have anticoagulation effect. If we compare heparin and warfarin, we will see that heparin can be used parenterally, intravenously or subcutaneously, but not intramuscularly, while warfarin can be used orally. Heparin have intermediate onset of actions for around 4 to 6 hours, while warfarin have delayed onset of action that can last for 3 to 6 days. Activity in vitro and in vivo, while it has only in vivo activity, and that means that we can use these heparins in the blood collection tubes, which will inhibit the coagulation of blood that are collected within these test tubes. But we cannot use warfarin there because it needs biological environment to be effective. So in vivo are type of experiment which are done within living organisms like animals or humans. But in vitro involves only do not involve human or animals. Activated the mechanism of action. If you look into the mechanism, heparins activate the antithrombin 3 factors, and which blocks the action of factor 10 and 2, while warfarin is a vitamin K antagonist. So it inhibits vitamin K reductase and inhibit the synthesis of clotting factors. The antagonist for heparin is protamine sulfate. Here we have vitamin K. This can be monitored through APTT, while we can use for this we can use PT or NIR anticoagulant test. So you don't have to go into the mechanisms of these tests, but you just know that what are these tests used for. These are types of anticoagulant tests. Lepirudin and Bivalirudin, these are the direct inhibitor of thrombin and have been approved to provide intravenous anticoagulation in patients with heparin-induced thrombocytopenia. So it can be used in those patients who with heparin-induced thrombocytopenia. However, no antagonist is available so far, and the adverse effect is bleeding and hypersensitivity. Okay, now the third class in this category is the thrombolytic drug. So if you have remember or recall the formation of clot formation, what happens after clot formation? These plasminogens, which are inactive form, they are activated to plasmin, and plasmin causes the degradation of this already formed clot. So what we have to do, we have to increase the conversion of plasminogens into plasmin to activate the degradation of already formed clot. So thrombolytic drug causes lysis of already formed clot. Fibrinolysis is initiated by the activation of proenzyme plasminogen into plasmin, and plasmin catalyzes the degradation of fibrin. So here we have to increase this reaction, and for this purpose we have drugs that are called altiplase and streptokinase and urokinase. So these are the second generation drug, more safer as to compare to this streptokinase and urokinase, which are the first generation. They were previously known as tissue type plasminogen activator, TP, and that's why the abbreviations came from. Treatment of that can be used for the treatment of myocardial infarction, pulmonary embolism, and ischemic stroke. So we can use this for the treatment of already formed clot, while the others, antiplatelets and anticoagulant drug, we can use them for the prevention of these clot formation. The adverse effects, of course, again, bleeding, including gastrointestinal and cerebral hemorrhage. So this can be more complicated. Several studies shown that fibrinolytic drugs reduces mortality if given within 12 hours of the onset of symptoms. So it can reduce the mortality if it is given within time. So that's all for the antiplatelets, anticoagulant, and thrombolytic drug. So in order to summarize, we have discussed antiplatelet drugs. And antiplatelet drugs consist of COX inhibitor, aspirin or thromboxane inhibitors, glycoprotein 2B and 3A inhibitors, receptor antagonist, epzizumab is a monoclonal antibody, right? This is a synthetic one. And then we have discussed the adenosine diphosphate inhibitors. Ticlopidine is the main class in the end. Phosphodiesterase inhibitor, which increases the cycle CAMP, and thus causes the inhibition of calcium release from the calcium store. So all these drugs leads to antiplatelet effect. In the anticoagulants, we have discussed the heparin, low molecular weight heparins, and unfractionated heparins. The antidote for heparin is the protamine sulfate, or for the warfarin, the antidote is vitamin K. Where the Diphosphate thrombin inhibitors, we discuss Lepirudin and Bivalirudin. While in the thrombolytic drugs, we have where we discussed the streptokinase and alteplase drugs. So they causes the lysis of the already formed clot. So that's all for my side. If you have any questions, you can email me or you can contact me through phone, and I will be happy to answer. Thank you.